Uh, Thank you very much for the invite to this course. And so I'll be talking on, can I have my slides? So before I start, I'll tell you a small little story which happened about 10 years back. Some patients were being referred from a place in Uttarakhand, and we started getting end-of cases from them, and they were turning out to be fungal endophthalmitis, and it'll keep happening from the same institute every few weeks. And the surgeon was brilliant, and he got perturbed. He closed down his OT, did everything. And then when everything was ruled out, on the phone I told him, why didn't you take a swab for the undersurface of your operating microscope? That is the lens. They took a swab from there. We grew the same organism which we were growing in the end of cases. So it's very important to think out of the box when you're having cases like this, because you might, after following all the protocols, still not hit the nail on the head. Okay? So I'll go ahead with this clinical diagnosis, differential diagnosis. So basically, endophthalmitis, you can diagnose by history. You will have history of surgery having happened, diminution of vision. You can have pain, chemosis. Then you can have signs of inflammation, where you have redness, ciliary tenderness, aqueous flare, hypopyon, pupillary membranes, poor view of the fundus, vitreous exudation, and you may not be able to see much. Then you diagnose by ultrasonography findings, which suggest whether there is endophthalmitis, and then you do the lab investigations, where you can do a tap, a vitreous tap, aqueous tap, do a gram stain, KOH, culture and sensitivity. So it's actually become extremely important for us to differentiate between an endophthalmitis which is not infective, or we can call it a sterile endophthalmitis or TASS, and a infective endophthalmitis. So this particular term actually was coined many years back in 2006. We really don't know the exact incidence, because they sometimes get treated, they are mild cases, they're treated like post-operative inflammation. And it's important, however, to know that there are multiple causes, as Dr. Jalpa has just said, that you can have causes like detergents and enzymes in the instrument tubings, your ETO gas residues, talc from the glove, or you can have residues within the solutions which you use during your surgeries, the preservatives in them, all of them can cause it. So this is a table which basically differentiates what TASS is. If you have lid swelling, chemosis, and pain, then you think in terms of infective. If you have a corneal edema, which is limbus to limbus, you think in terms of TASS. If you have localized edema, then you think in terms of infection. The IOP is generally in infection, not increased, but it may be initially high in TASS and then can come down. On B scan, you will have vitreous opacities by which you can actually differentiate, and culture definitely yes. So this is just an example of a patient who was a non-diabetic, post-RK, underwent cataract surgery. This is how the patient followed over a period of time with intensive steroids, no intravitreal antibiotics. So it's important for you to know how much trauma was caused during the surgery, and for you to know that your protocols are good and whether antibiotics are required. Another patient of TASS, patient did well just with intensive steroids, of course with topical antibiotics and no intravitreal injections. So once you are suspecting, it's important to know how to take the sample, how to transport it, and how to send it for cultures. So these are some of the examples, a two-handed technique where you can do it with a 26 gauge needle, and this was done by Harry Flynn, where you can do it on a scalp vein. And this is during a vitrectomy, where you can do it before you start a vitrectomy. You can do it in the cutter itself. So once you've got the sample, you can, in your own, this thing, you put it in an ETO bag, transport it, or store it at 4 degrees Celsius and transport it later, or you can directly inoculate in your operation theater. And for that, you need all these samples, so that you have to have all these in your operation theater to do it, or you send it to the lab for doing it, because you need to reach a diagnosis. So if you have Pseudomonas growing in, then you can suspect that it is from the supplies. That means all your instruments, all the solutions. If it is a Staphylococcus or gram positive, then it could be from the personnel. That means your OT staff could be the source of infection. And if it is bacillus, then you can think many people still send their OT clothes to somebody to wash, dry, and send it back. We don't know how they are drying. They may not have dryer. They put it on the roadside. उसमें dust आती रहती है, and then the same clothes come inside. So all these things are a problem, and you need to know. Then you can have PCR diagnosis. You can do it with X-cyton, which is in by these are all DNA-based diagnoses, and they have various protocols, various organisms, and you're able to get the diagnosis very rapidly. Look at this report which came out from EVS and LVP. The difference is that we have a higher percentage of gram-negative bacillus as what came out in the EVS study, and that is important for us to know. The incidence of there's a high incidence of gram-positive cocci, but also of gram-negative bacilli, which is extremely important. Now, it's important to know that supposing you get a case, what clinical signs would help you to differentiate a reaction in the AC on day 1 after cataract surgery? So you must be able to correlate with surgical trauma. You must be able to see if there's a vitreous involvement and then take a decision. Then a question is normally asked, when should I call my patient after cataract surgery? It should be day 1, day 2, day 3, day 4. Usually it should be within the first 3 days, because if it is a very severe endophthalmitis, it will present within 12 to 24 hours. But if it is slightly less severe, at least within first 3 days, you must see your patients. Now, endophthalmitis hence can be classified as acute, subacute, or chronic, or it can be classified based upon the etiology, or it can be exogenous and endogenous endophthalmitis. So acute post-operative, post-cataract surgery endophthalmitis typically is because of staph epidermidis, but then you can have it because of Staphylococcus aureus, other streptococcus species, Pseudomonas and all can also cause, but commonly is staph epidermidis. Now, this is a case who presented and there was a hypopion. So when you have a hypopion, it is always better to err on side of infection. This is just to show you that you can treat your patients extremely well with intravitreal antibiotics. Patient was given Bancosefta. Patient was followed with topical and systemic, topical antibiotics, systemic antibiotics and topical steroids. And over a period of time, patient did well. So it's very important. In 90% of these cases, if you intervene on timely manner, you can treat these patients with intravitreal antibiotics alone. Now comes bleb-related endophthalmitis. This can be caused more commonly by Streptococcus species and also by Haemophilus influenza. And these are some of the risk factors which are there, and you can have infection of the bleb, which you can see it clearly. And this has been, you can look it up, there is a classification which says what are the stages of bleb-induced endophthalmitis and how you should intervene when you have different stages of endophthalmitis caused, which is bleb-related. Post-traumatic endophthalmitis, usually you have to look in terms of bacillus cereus. This is usually from either, depends upon the trauma, it is either with a vegetable matter or a metallic particle, and accordingly you decide how these patients are going to behave. Now, P. acnes is a gram-positive anaerobic bacillus. It usually causes a delayed infection. It can also happen after yak capsulotomy, and it is an interesting fact to remember that the acne and pimples which are caused is by the similar organism which is P. acnes. So people who have this pimples, people who have this acne and also are undergoing surgery, the chances of P. acnes is high. This is a patient who presented with a plaque-like thing, visual acuity was 6/18, and patients were treated with vitrectomy, intracameral and intravitreal antibiotics, and this is 4 weeks after pars plana vitrectomy, patient did well. So it's important to intervene timely. Then you can have fungal endophthalmitis, and these patients actually, the signs are more than symptoms. The eye may be quiet. It can present as, so normally we were taught that fungal endophthalmitis is usually delayed presentation, but you can have it within the first 4 days after surgery. You can have it within 10 days. You can have it after a few weeks after surgery. And this usually is a chronic endophthalmitis. Usually it's a thick hypopion which doesn't shift with position. And you can have other signs within the fundus of snowball and fluffy opacities in the vitreous cavity. So all eyes, typically fungal endophthalmitis, have minimal pain and congestion. The exudation is predominantly limited to the anterior segment, and all these patients, we treated them with intracameral and intravitreal voriconazole with AC wash and vitrectomy, and they did well. We try to avoid removing the lens, IOL, but if required, it should be done. Now, this is just an example of cases which I present to you because the management will be discussed later on by Dr. Chaudhary. So this is a 45 years type 2 diabetic patient. Post-op day, patient was treated with Vanco, Tazobac, and a microscopy was done. 48 hours later, the patient was not responding, had undergone a revitrectomy with Vanco amikacin. The hypopyon came back the next day. And then the patient said, I would like to take a second opinion. Patient underwent a second revitrectomy with a voriconazole. Vitreous sample was sent for PCR, and see what happened. The vitreous sample actually grew Bacteroides fragilis. We gave intravitreal injection of imipenem. Patient responded the next day. So what I'm trying to tell you is, it's extremely important to make an organismal diagnosis. If you do not make an organismal diagnosis, you can keep on doing vitrectomy and the things won't respond. Another patient was treated with Vanco-Tazobac. 24 hours later, the hypopyon increased. We did a vitrectomy, imipenem, microscopy. Patient's microbiology was negative. Patient was given a revit. A PCR was sent. Then we give linezolid with it. PCR grew Pseudomonas aeruginosa. Patient was then given intravitreal injection of colistin, and patient responded well. So these are all, again, organismal diagnosis will be able to save the eye. And this is what happened. You must have heard of the catastrophe which happened at PGI Chandigarh. So these are some slides which I got from Dr. Vishali. There were 28 patients who received this injection of bevacizumab. And this is the various diagnoses for which they were given. All these patients, now suddenly on that day, patients were one of the patients came back with infection. All the patients were called back. That was in the afternoon at 3 p.m. The smear grew gram-negative, showed a gram-negative bacilli. Now they had to pinpoint the diagnosis. So there was a test known as Malditov, which had never been tested before. So they applied the Malditov test, and by 7 p.m. they had the diagnosis of the organism, and this came out to be a very strange one, Stenothermophilus, a pseudomonoid organism, which was sensitive to ceftazidime, the levoflox, cotrimoxazole, minocycline, and 17 vitrectomies were done in these cases. Again, I'm pinpointing that it's important to pinpoint the diagnosis. This is another situation. Somebody said that if you have an implant in the eye for 1 year, and after 1 year, it can't be, you can't label it as this is a 5-year history of a patient, or 5-year follow-up of a patient of a chronic endophthalmitis. Patient received 2 vitrectomies, 14 intraocular injections of antibiotics, multiple injections of Avastin for DME, considering it to be a masquerade. PCR was negative, vitreous cytology was negative, PET-CT was negative, patient also received methotrexate, and then you have to think out of the box. So we thought how to hit the organism. So what we did was, this is a small little video. I said, now the vitreous cavity had been all cleared up by multiple vitrectomies. So I decided to take the sample from the zonular area. You can see here the specially made cannula, which is very simple, with a large 26 gauge needle. I go inside, take samples from different sides, take samples from the aqueous humor, take samples from the zonules of both the sides, and this was then sent for, you can see the things coming off. And we went ahead and did the vitrectomy. So these are some of the ways we took the curved cannula, and we sent, now this we sent to SN as well as Exciton. In SN it grew P. acnes, in Exciton it grew Fusarium. So again we are confused. So we went ahead and treated for both, and patient did well. So basically saying that organismal diagnosis is very important. I would not go into the details of indications for vitrectomy. That will be covered by Dr. Chaudhary. So in the end, you must be able to, this is just to show you the grading of opacity. So if you have an inflammation which you can't explain, think in terms of infection rather than inflammation. Do not ignore any symptoms of the patient. If the patient talks to you on the phone, call them to your clinic. Don't answer, don't tell them, don't give advice on the phone. It's very dangerous. You must be able to document. You must be able to talk to your patients repeatedly. Do try to prove the diagnosis. Do not hesitate to give an intravitreal injections. And if you cannot handle, send it to a colleague who can do a vitrectomy. Thank you for your kind attention. So this is basically what I have already covered. Thank you very much.